that the Professional Development Committee have been able to secure Professor Deborah Fella, who is the Professor of Physiotherapy at Birmingham University and also Director of the Centre of Precision Rehabilitation for Spinal Pain. Thank you very much, Deborah, for delivering this lecture.
Thank you very much. So this evening I'll be speaking about motor adaptations in people with spinal pain and discussing the implications for exercise prescription. Just to start, I'd like to set the scene just by briefly reviewing the enormous burden of spinal pain. Now this slide here presents, I don't expect you to of course read the text on this slide, but rather focus on the colours. So this slide is presenting the top 10 causes of years-lived with disability. Red is back pain, yellow is neck pain. And the first row here represents the global scenario, followed by developed countries and then developing countries. And you can see that overall, globally, back pain is in first place, neck pain ranks in fourth place. The UK is around here on the slide, and you can actually see, although back pain is consistently in first place, neck pain actually often falls into second place or third place. And the problem is that this enormous burden of spinal pain continues. So if we look at the rankings back in the 1990s, for instance, and we compare them to current day rankings, you can see the situation hasn't changed. So despite massive efforts, the rehabilitation of people with spinal pain simply remains suboptimal. Now, the other important feature about spinal pain is that it tends to be persistent or recurrent disorder. And indeed, up to 85% of people can expect to have some degree of ongoing pain following their first episode. And so the course of spinal pain is often best described as a number of episodes with varying degrees of recovery between episodes. And so, of course, what that implies is that the challenge is not just to resolve a patient's acute pain, which is often fairly easy to achieve, but actually to prevent or to limit the recurrence for future quality of life. And if we think about why patients have recurrent symptoms, then obviously we have to think about the patient within the context of the biopsychosocial model. So there will be biological factors, psychological factors, and social factors contributing to the patient's presentation and to persistence or recurrence of symptoms. But we also know, of course, that the various different domains of the biopsychosocial model are fluid and that they will vary in their contribution between different patients, and actually often will vary in different stages of the patient's spinal pain presentation or disorder. So of course there will be many patients where the biological factors outweigh psychological factors or social factors. But likewise, of course, there will be other patients where the psychological factors outweigh any biological or social factors. And again, there'll be other patients where the social elements become particularly relevant. What I'd like to do within my presentation is focus more on these patients where biological factors, and I'll particularly be focusing on neuromuscular control, can contribute to ongoing symptoms or recurrence of symptoms. So within this lecture, I plan to address these 3 points. And the first is to review the fact that neuromuscular adaptations are diverse in people with spinal pain, that adaptations can be individual specific. And then what I'd like to do to finish off is talk about management and how we can potentially optimize management through more targeted interventions for patients with spinal pain. So let's start with point number 1. So neuromuscular adaptations are diverse in people with spinal pain. And by diverse, I mean that they range from very general adaptations right through to very subtle variations in the way muscles are behaving and the way movement is being performed. And if we firstly start with the more general adaptations, these are very well known. There's an abundance of literature describing general motor adaptations to pain. And these, of course, include typically decreased strength, decreased endurance, decreased range of motion, slowness of movement, delayed responses, decreased rate of force development, power, proprioception, and so forth. I don't want to focus my presentation on those, but rather actually focus more on some of the more subtle variations that we've seen through our more recent research, looking at very subtle variations in the way muscles are behaving and the way movement is being performed. And these subtle variations have been seen thanks to advances in the field of electromyography. And so compared to the classic approach where we simply place a pair of electrodes over the muscle and record a signal and measure amplitude, for instance, by placing a grid of electrodes with high density EMG, we can now obtain multiple signals, and from those signals generate a topographical map of the EMG amplitude. And so essentially here you can see a map of the lumbar erector spinae activity, where red zones indicate regions of the muscle with higher activity, blue indicates regions with lower activity, and you can see that there's a non-uniform distribution of activation across the lumbar erector spinae. And in particular, we can actually measure the center of activity, and that's illustrated by that black circle here, and monitor how that circle shifts, or how the center of activity shifts, both along the longitudinal and transverse axis during both sustained and dynamic contractions. And one of the most relevant findings revealed by electromyography in the last decade or so has been the fact that muscles do have a non-uniform behavior, and that spatial distribution of activity changes during contractions, and that it has the physiological significance of minimizing muscle fatigue. Okay, so redistribution of activity prevents overload on specific muscle regions, and once again, it has a physiological significance of minimizing muscle fatigue. So by using this technique, we literally have an opportunity to almost image muscle activity in real time and monitor how it changes during either dynamic contractions or also sustained contractions. So I'd like to show you some of our recent work using this technique in spinal pain. And you have to excuse my voice, by the way. I've been suffering with a bit of a flu for a couple of weeks, and so I apologise if my voice keeps failing on me. Okay, so the first study is on low back pain, okay? And this is a study where we've had people with chronic low back pain, healthy controls, performing a repeated lifting task. And essentially, this first slide simply shows you that in terms of a gross measure of spinal movement, people with low back pain in orange had significantly less movement, and that was particularly noted towards the elevation phase of this repeated lifting task. And the other important point about that task was that it was provocative. So in terms of the patient's pain intensity, it significantly increased across the duration of this 3-minute repetitive task. But of course, the purpose of showing you that study was to show you the EMG results. And so here, on this slide, we have representative topographical maps of the EMG amplitude recorded from the lumbar erector spinae from a representative control subject. And this is a map taken at the beginning of this repetitive task, towards the middle of the task, and towards the end of the task. And the main thing to see there is that the distribution of lumbar erector spinae activity is changing progressively over time. And you can see that when you focus on the black circle, because you can see that it's progressively shifting down towards the caudal region of the lumbar erector spinae. And remember, as I said previously, a number of our earlier studies had confirmed that that redistribution of activity has the significance of minimizing muscle fatigability. Now here we have an example from somebody with chronic low back pain. And although you can see that the amplitude is increasing progressively over time, over the course of the task, the important observation is that the distribution of activity is not changing. So it's essentially, it's the same region of the muscle that's becoming progressively more active over time. So you don't see that shift. And of course, not surprisingly, this was a more fatiguing task for our patients with low back pain. So that was representative data. This is just providing the results at the group level. So comparing our patients in orange to our healthy controls in blue. And this is a measure of the shift in the center of activity along the y-axis, okay, along this axis. It's not so intuitive because higher values actually are in the caudal direction. But the main thing to see here is that regardless of whether it was the lifting phase of the task or the lowering phase of the task, you can see that our patient group are showing that clear shift in the centre of the activity towards the caudal direction, and we didn't see that across the low back pain participants in that study. And interestingly, what we've also identified and what we've also seen through studies is that that lack of redistribution of activity is also associated with less variability in the way people with low back pain are moving. And you can see this on this slide here. So in addition to recording EMG, during that repeated task, we've also measured movement. And we've done that by having strips of sensors that are placed either side of the spine. And each strip contains 12 sensors, which roughly corresponds to 12 spinal segments. And because this is a very repeated task that they're doing, we can sort of filter off the frequencies related to the main task itself and actually focus more on the accessory angular dynamics of the task. And we've used a particular analysis to look at the variability in the way people are moving and the complexity in the way people are moving. And we've done that through a technique called recurrence quantification analysis, which essentially gives us a measure which is called the percentage of determinism. But without going into detail, the main thing to know is that higher values means that the movement is less random, okay, or it's done in a less variable way. And you can see that regardless almost, or at least consistently over most segments, people with low back pain did present higher values of that measure, which once again is a measure of the variability in the way they're doing their movements. So we found that the people with low back pain tend to perform the movements in a very standardized way with less variability or subtle variations in the way they're moving. Now, when we look at our findings with electromyography in terms of the change in distribution or lack of in people with low back pain, you can look at that data and think perhaps those people actually were like that before they even had pain. Maybe that was the way the muscles were activating anyway prior to pain onset, and maybe that's even the reason why they even developed, or part of the reason why they developed low back pain. But we've got very convincing evidence from experimental pain studies that it's nociception that is the initial driver to induce such an adaptation. And we've seen that through experimental pain research. So this is an example of a study where we've had asymptomatic people perform once again the same repetitive task. And once again, we've acquired high-density electromyography from the lumbar erector spinae. And we've done that at baseline, so they've done the 3-minute task, they've had a break, and then we've injected hypertonic saline into the lumbar erector spinae. And the injection of hypertonic saline induces a moderate intensity of pain. It's typically around 5 or 6 out of 10 on a VAS, and it lasts about 10 minutes, 5 to 10 minutes. But essentially allows us to get the people to repeat the task when they have pain. And if you look at the measure of the shift of the centre of activity along the longitudinal axis, in the baseline condition, we can see the shift, but when we've induced pain in our healthy volunteers, you can see that we've effectively blocked that shift. So once again, convincing evidence that nociception, in fact, is the initial driver. This is not a unique observation to the back muscles. This last example is just to illustrate the point that this has also been seen for other muscles. So this is now a neck pain example. Similar sort of format in terms of having people perform a repetitive task. This time they're seated but repetitively lifting a box up and down. And we've measured now the distribution of activity of the trapezius muscle, the upper division of the trapezius. And we're measuring the center of activity along that longitudinal axis. These 3 conditions here are a baseline condition, an isotonic saline condition, which is a non-painful injection, and a recovery condition. And the point to see is that normally different regions of the trapezius muscle would be engaged depending on the height of shoulder flexion. Okay, so different regions of the muscle are recruited because they're optimally designed to contribute to the task at that point. When we then inject hypertonic saline and produce an experimental neck pain condition, then you can see that actually we don't get the same cranial shift of the upper trapezius that we would normally get in an asymptomatic scenario. So different regions of the muscle are not being engaged as they should be. And that's just representative maps just to illustrate under the 3 baseline conditions. You can see very consistent activation of the upper division of trapezius, but in the painful condition, there's been a caudal shift actually of the activation so that the upper fibers of the upper trapezius are actually significantly less activated during the painful condition. So if I come back to that point, the first part of the presentation was just to illustrate that motor adaptations, of course, are diverse. We have a lot of evidence on the more general adaptations and increasing amounts of evidence on these very subtle variations, which of course are the underlying driver for the more general motor adaptations to pain. My second point is that the adaptations can be specific to an individual. So if we think about what we've just seen so far about these general adaptations and these subtle adaptations, although we see very common adaptations in people with pain, it doesn't of course imply that every person is going to present with exactly the same variations in motor function, whether it be general or whether it be specific. And on the contrary, what we do see is that although there are common observations, they're certainly not universal across people with spinal pain. So if we come back to this example that we've just been looking at, which is the study which showed that people with low back pain on average tended to have a lack or less redistribution of lumbar erector spinae. That was the overall conclusion in that study. But actually when we went into the data and looked at individual responses and how each individual with low back pain behaved in that study, we actually found that 26% of the low back pain patients showed what was considered to be a relevant shift in the centre of activity. So in other words, 26% of the cohort behaved in the same way that our asymptomatic subjects did. And this is just one example here from another person with low back pain where you can see that they've effectively have that redistribution of activity. So once again, common is not universal. And to illustrate that point a little further, I'd like to consider a classic example in neck pain. Because one of the very common observations that has been seen in research in neck pain is heightened activation of the sternocleidomastoid. And so here's 4 different studies, each measuring the same thing, albeit in different cohorts of people with neck pain disorders. So each study here is measuring the activation level of the sternocleidomastoid muscle during a task of craniocervical flexion. You've got one study on cervicogenic headache, you've got one on whiplash, you've got one on idiopathic neck pain, and you've got one on work-related neck pain. In each graph, the white line represents asymptomatic people, the coloured lines represent the patients. And you can see very consistently, each study has shown that the patients present with higher activation of the sternocleidomastoid muscle on that task. So it is a very common observation. Yet what you don't see in those studies, of course, is the individual data. Yet if I show you some individual data from one of those studies, you will see, in terms of sternocleidomastoid activity on this craniocervical flexion task, yes, there were many participants that had very high levels of activation of the sternocleidomastoid. Yet there were also several participants that had activation levels that were perfectly in line with the asymptomatic group. So although it's a common feature, it's certainly not present for every particular person that we come across that has a neck pain disorder. And in fact, going back to our experimental pain studies, we've learned that people have very individual motor adaptations to pain or to nociception. And to illustrate that point, I'll just show you this one example. So it is an experimental pain study, which of course has the advantage that we can standardize everything. Okay, we can standardize the noxious stimuli, we can standardize the measurements and so forth. So these are asymptomatic people, and they had a task. They were seated in front of a wall, and their task was to do a head-neck, almost like a pointing task. So there are a number of peripheral targets and a central target. They're sitting with a helmet on, laser pointers on the helmet, and their task is to a beat, is to move their head to orientate the laser pointers from a peripheral target to the central target, peripheral target to the central target, and so forth. And as they've done that, we've used EMG to measure multiple neck muscle activity. We've done that at baseline, and then we've done that immediately following injection of hypertonic saline into the splenius capitis, the right splenius capitis. And if we look at the results overall, so average for the group of subjects, what we can see is that different muscles behave differently overall in the presence of that noxious stimulation to the splenius capitis. So here, there's an indication for the various different muscles that we've tested, whether their activity either decreased in the presence of pain or increased in the presence of pain. So the threshold of 1 implies that the activation was the same in the baseline condition versus the painful condition. In red is the muscle that we've injected, so we've effectively inhibited that muscle. And you can see that other muscles have increased or decreased their activity overall when we look at the group results. If you look at the sternocleidomastoid, you will see that its response was to increase overall at the group level. Okay, that's quite consistent with what we see clinically in many patients. However, if I now show you the individual data from each subject in the study, what you will see is that everybody had their own unique combination of adaptations to that painful stimulus. So here what we have is for each of the 8 people enrolled in the study, an indication for the various different muscles that we've tested, whether the muscle activity increased in the presence of pain, and that's indicated by orange, decreased, which is indicated by blue, or remained unchanged, which is indicated there in white. And if you look at the sternocleidomastoid, this is the right sternocleidomastoid, it's the second row there, you'll see that yes, most people in fact did have an increase in activation. But there was actually one person that showed a decrease in sternocleidomastoid activity, and there were a couple that remained unchanged. And likewise for the left sternocleidomastoid, it's here. Most people increased, 2 decreased, 1 remained unchanged. So very individual responses. And in fact, if you compare across the 8 subjects, you will not find 2 that behaved in the same way. Okay, so everybody presented with their unique mix of changes in muscle behavior. And then my last point is to consider what those first 2 points actually imply for the management of people with spinal pain. So if we think about management of spinal pain, then of course exercise really is the cornerstone of the management of spinal pain, and of course it's also effective in the prevention of spinal pain. However, we have a bit of a problem in that systematic reviews of exercise for spinal pain invariably only show small to moderate treatment effects, and any effects that are there rarely last. And then the other problem that we have is there's very little evidence of superiority of one exercise program over another. So we need to understand why. And I would argue at least part of the problem relates to these diverse and individual motor adaptations, such that the often applied one-size-fits-all approach to spinal pain or exercise for spinal pain is obviously just simply inadequate. So if we think about reviewing the literature and thinking about the various different motor adaptations or sensory motor adaptations that we see in spinal pain, as I've said already this evening, they may range simply from a reduced range of movement right the way through to these very subtle variations in the distribution of activity. But of course, that doesn't imply that every patient is going to present with all those problems. And on the contrary, as we know, each person will present with their own unique mix. There'll be patients, for instance, that it's mainly fear of movement that's driving the motor adaptations. There'll be others where they do have these very distinct changes in the way the muscles are behaving that are loading the tissue suboptimally, contributing to nociception, contributing to ongoing pain. And then there may be other patients where it's largely sensory disturbances in terms of body perception and proprioception. Yet despite that variability, it's of course quite a common approach, and it certainly is in research, to pop everybody into the same exercise program. And it's really not surprising that we end up with these small to moderate treatment effects which simply don't last. So to illustrate that point, I want to come back to this example that we've just seen. So this is the example where we saw that it's a really common finding in people with neck pain to present with heightened activity of the sternocleidomastoid on the craniocervical flexion test. And of course, earlier work had shown a direct relationship between heightened activation of the sternocleidomastoid and reduced activity of the deep cervical flexors. And so craniocervical flexion training became a really popular form of exercise for people with neck pain. It still is. And of course, there are a number of clinical trials that support that type of training for people with neck pain. This is only just a part of what's out there. So there are many showing that that form of exercise is effective for reducing neck pain, reducing disability, reducing headache, dizziness, etc., etc. But the problem is, although it is shown to be effective overall, and it's been shown in various different neck pain populations, at the end of the day, when we go into the data and we do it in detail, you will see massive amounts of variability. So we see that there are some people that get absolute complete relief of their symptoms just by doing 6 weeks of that exercise program. But at the other end of the spectrum, there are other patients that have absolutely no benefit or only a very marginal benefit. And of course, the reason why we see such variability is because a lot of the patients in that study, or those studies, didn't necessarily have that particular neuromuscular adaptation. And to illustrate that point, I'd like to show you this study, which essentially was a clinical trial on people with neck pain, and they just did one exercise every day for 6 weeks, and it was the craniocervical flexion training. So every day, twice a day, for 6 weeks, they performed that exercise. And what you can see here is the relationship between the activity of their deep cervical flexors before training and the amount of improvement in the activation of their deep cervical flexors after training. And you can see a clear relationship there, yeah? So the people that had the least activation up here, down there, at the beginning of training were those that had the greatest improvement. And that makes sense in a way because they had more room for improvement. But where it becomes particularly relevant is when we look at the relationship to symptomatic relief. So this slide shows you the relationship between the amount of improvement in activation of their deeper cervical flexors and the amount of change in their pain intensity over that 6-week period. And once again, we can see a relationship there. So the people that had the greatest improvement in the activation of their deeper cervical flexors were the people that had the greatest pain relief. But there were people in the study that had no improvement whatsoever. And as you've just seen from the last slide, that's because they didn't have a problem with their deep cervical flexors in the first place. So the variability in response to exercise is at least partially driven by the variability in the underlying neuromuscular adaptations that we see in people with spinal pain. So when it comes to optimizing management, there are different levels, obviously, in terms of optimizing exercise prescription. And obviously one of the first points is to understand really what is the key driver for the patient's pain and for the patient's recurrent pain. And of course it could be pathology driven, but as we know in many patients it's not possible to identify a pathoanatomical source of their pain. It may very well be psychosocially driven, including negative beliefs, depression and so forth. But certainly in a proportion of patients, it's going to be movement driven, where they do have altered muscle activation. It's leading to suboptimal muscle use, loading of the tissues, and ongoing nociception. And then, of course, there could be central sensitization and other factors which are going to be interfering with response to exercise as well. So when it comes to identifying appropriate exercises for patients with spinal pain, obviously that means that we need to obviously rely on a multi-system assessment. What are the various different physical factors that the patients present with? We have a lot of knowledge on the type of motor adaptations that occur in people with spinal pain, remembering that they can go from those more generic adaptations right through to very subtle variations. The biological factors, which of course negatively impact on exercise results, psychological features which are clearly relevant, and social factors. And once we've done that, we're in a better position, of course, to identify components of exercises that are better matched to the patient. And that could be more the motor control training, where we aim to optimize loading and optimize muscle use to reduce nociceptive input. But likewise, it could be just general strengthening and endurance, using exercise for its analgesic properties, or exposure to reduce threat, or changing exercise beliefs. Okay, so various different components. And then from there, really developing individualized strategies to match the patient's unique mix of presenting or their presentation. And that's the work that we're currently doing and moving forward at the Centre of Precision Rehabilitation for Spinal Pain here in Birmingham. And to finish on a final study just to support that point, I'll show you one last clinical trial, which was an exercise trial for low back pain. And essentially it was a study which compared motor control training versus graded activity, following a more cognitive behavioural therapy approach for chronic non-specific low back pain. What you can see here is that this was a 2-month intervention, is that after the 2-month intervention, both groups had a significant improvement. This is the very common finding in the literature. Exercise is good, but it doesn't seem to matter what you do, okay? It's all good, but there's not a lot of difference between the type of exercises. But what was also done in the study is that before they started training, the patients had to complete a questionnaire. And essentially it was a questionnaire designed to identify or detect the contribution of a nociceptive component to the patient's presentation. So physical features dominating the patient's presentation. And then they were grouped into either having a positive response to that questionnaire or a negative response to that questionnaire. And when they did that and then looked at the response to the various different, or the 2 different exercise interventions, and you can see, for instance, if we look at the graded activity, you'll see that the people that actually did the very best were those that had a negative response to that questionnaire versus those having a positive response. So we're starting to see a clear difference in response to exercise based on the patient's presentation. And of course, the opposite was found for the motor control group. Those with a positive response to the questionnaire did much better with the motor control program versus the graded activity. And as said, this is work that's continuing on to further support the approach to more targeted interventions for people with spinal pain. So I'm going to finish there, and as I said, that today was about really looking at the diversity of neuromuscular adaptations and presenting some of our recent work on subtle variations, reviewing the fact that individuals do adapt differently, and taking that knowledge together, we're in a better position to hopefully target that recurrence of spinal pain moving forward to the future. So I'll finish there, and I'll say thank you very much for the invitation to be here tonight. Sorry about my voice, I don't normally sound like this. And thanks to the team at the University of Birmingham and a number of people that contributed to the studies that I've presented tonight. So thank you very much.
Thank you very much, Deborah. That was a fascinating talk. It covered so much, and we really do appreciate that. I think we've got time for a couple of questions. Does anyone have a question for Deborah that they would like to ask at this point?
Hello, Deborah. What was the questionnaire used for the most recent study, the placebo?
It was designed for the trial.
Okay.
So if you go to the paper, it's actually presented, but it was specifically designed for that trial.
Are you thinking of validating?
No. I wasn't actually involved in that study. So that was a study that was done by a different group, and I wasn't involved in that. If they plan on validating it, I don't know. I don't know.
There was another question over here.
I was just interested in your thoughts on the reasons why you'd have increased activity in the sternocleidomastoid, whether there was I don't know, an evolutionary reason for it, was it protective?
Potentially, yeah. I think what we tend to see is a lot of co-activation, and so it's not just the sternocleidomastoid, but